1, 2, 3, 4. One, two, three, four. Hello again. Light. Hello again. For those of you that are new to the channel, my name is Jonathan Downham. I'm an advanced critical care practitioner in Birmingham in the UK. The coronavirus is beginning to have a real impact on us now, and one of the ways that we are planning on combating this is to have eventually, and this sounds really scary, one ITU nurse to every 6 patients. Now, in order to facilitate that, we're going to have a lot of helping hands working with us, people who aren't necessarily experienced in intensive care but can do a lot of the basic nursing care. So they can wash the patients, for example, they can give the drugs, they can help us turn the patients, they can answer the phones. So it's going to require a lot of hard work and cooperation. And whilst those people new to intensive care aren't necessarily going to be required to look after the ventilator, I just thought this might be nice if you're going to go there for you to have some understanding of the basics. Now, I've got to give a big shout out here to SamIam_UK. Samantha is a relatively new ITU nurse. You have to forgive me, Sam, I'm not sure where you work. I have spoken to you in the past, but I can't remember. But she's produced some wonderful resources which she's made free and open access, so I am using them. I have asked her if I could and she said yes. So a lot of this, a lot of praise goes to Sam for this. So without further ado, let's talk about some of the ventilation basics. Remembering to change my screen because I forget. So there we go. So I hope you can see that okay. We're going to talk about the ventilation basics. So, and you'll have to forgive me, I'm using a pen tool that I've not used before. So let's talk first and foremost about some of the, well, no, let's talk about why we ventilate. Okay, so why do we ventilate? Why are we ventilating the COVID patients without going into too much depth? The main reason is that they go into type 1 respiratory failure. So type 1 respiratory failure is where there is a shortage of oxygen. So their lungs start to fill up with fluid and gunk and muck in the alveoli and in the spaces surrounding the alveoli. Typically they can end up on 15 litres via a non-rebreathe bag. So they're on a lot of oxygen and they start to tire. And when they do that, that's when we need to take over. So we will ventilate them in order to be able to try and deliver more oxygen to them more effectively and enable them not to become exhausted. So we'll sedate them, we'll put an endotracheal tube down, and then we will take over their breathing for them. The other type respiratory failure is the type 2 respiratory failure. So a type 2 respiratory failure is where the patient's carbon dioxide levels go up. Typically that's not happening with these patients. They are very much a type 1 respiratory failure. You can have that complicated by some patients with a mixed type 1 and type 2, especially those with underlying respiratory disease. But let's just talk about the type 1s now. So we've ventilated these particular patients because of this type 1 respiratory failure, and we've put them on the ventilator. So if we just start with this first diagram here, which Sam has done. So let's choose a colour. Let's go for pink. So we start with the endotracheal tube. So the endotracheal tube is the tube that is going through their vocal cords and sits just in their trachea above the carina. And the carina is this region here. So this is where the trachea divides into the left and right main bronchus. And that's what allows us to get the oxygen into the patient's lungs. So the endotracheal tube is what you see sticking out of the patient's mouth. Different sizes Let's not worry too much about the sizes. At the end of the endotracheal tube, so if I just draw a quick diagram here, and my drawing skills aren't brilliant, so if this is the endotracheal tube, what you'll have at the end of the tracheal tube is a balloon going around the end of it, and then this part will be attached to the ventilator. And the balloon is inflated not to keep the tube in. The balloon is inflated because if you didn't have a balloon there, as soon as you injected the air in, it would then just come straight out. So you need the balloon to stop the air escaping from the patient's lungs. Let me just rub that out. Okay, so you've got your endotracheal tube at the top there. With the cuff, as you can see on here, going down into the patient's lungs, ventilating both of the patient's lungs. That is then, at the end of that, you will have an ET cuff inflation valve and puff pilot balloon. So you have a tiny little balloon coming out the end of the tube with a little balloon on the end of it. And that's how you inflate the balloon sitting in the patient's trachea. And that's how you know that it's inflated. So that will then also be attached to what's called a closed suction system. So a closed suction system is just basically a system that we use that means when the patient's trachea needs suctioning, we don't have to keep unattaching the patient from the ventilator and then suctioning them. And that's more important now than ever, because one of the things we're really trying to avoid doing with these patients is unattaching them from the ventilator, because as soon as you do that, especially if you don't do it in the right order, if you don't turn the ventilator off or pause the ventilator first, basically the ventilator will just spew air everywhere. So you'll get all this aerosolization of the coronavirus essentially. So we're really trying to avoid doing that. So the closed circuit suction basically means that we don't have to break the circuit. We can suction them without doing so. And these patients will require frequent suctioning. So that's quite important as well. Then you will have, beyond that, you will have the HME filter. So that's a heat moisture exchange filter. So it's doing literally what it says on the tin. It's exchanging heat and moisture, trying to keep those secretions nice and moist. Sometimes they're going to be humidified as well. That varies from trust to trust and from patient to patient. But these are very much the basics of the ventilator. So if we just focus, I'll just rub these out for now. If we just focus on this machine over here. So this is one of the standard ventilators. Okay, so this is a Hamilton ventilator. So you can see here at the screen, this is the information screen, which both provides us with information and with today's touchscreens technology allows us to input information as well. So this is where we can change the settings of the ventilator. And I'll talk about that when we go to the bigger diagram to one side. You've got the ventilation tubing coming here, so you've got ventilator tubing coming in and ventilator tubing going out, and then that is attached to the patient, like I say, via the closed circuit suction and via the endotracheal tube. So this is the kind of machine that you'll see. They're getting smaller and smaller as the years goes on, but this is a Hamilton. This is one that we use in our trust. Let me just get rid of those lines again. Okay, so let's talk about this screen here, and I might make this screen a little bit bigger if I can work out how, and I can't. So let's just go with the basics. Okay, so actually what I might do is... No, we'll work with this. Okay, so this is the screen that we've got. So we've got two sides to this ventilator. This is what the machine is telling us, and these buttons are what we are telling the machine. Okay, so we are setting the machine to do a number of things, and there's a number of key points that we need to be aware of. So first of all, we need to tell the machine there's various modes that the ventilator can do. Again, I'm not going to go too much into modes because this is just going to be the basics, and it's not something you're going to be expected to set and reset if you're not experienced in ITU. But that mode is dictated by these letters up here, and this one is PSIMV, and that's one that is quite common as well. The other thing you're going to be the machine is going to want to know from you is how often do you want the patient to breathe. So what is the patient's respiratory rate? And you can see here, this is the patient's respiratory rate. So on this patient, it equals 21 breaths per minute. Now, sometimes these breaths, and certainly in this mode we've got here, can sometimes be the patient's breaths, can sometimes be the machine delivering a breath, and sometimes can be a mixture of the two. So you've got a combination of the two potentially. It depends how sleepy the patient is. It depends how much we're trying to wean the patient. It depends how much sedation we're using. It depends on the patient's conscious level. But that's the respiratory rate. I'm just going to rub out some of these lines because otherwise it's all going to get really busy. Okay, so that's the respiratory rate. That's one thing that we set, allowing the patient potentially to do some breathing for themselves, but on the whole, certainly when they're at their sickest, the machine will be doing most of the ventilating for them. The other thing that is set is the tidal volume. So the tidal volume is just how many mils of air the machine, or air stroke oxygen, the machine will be delivering to the patient per breath. Now, the recommendation these days is that we should be delivering 6 to 8 mils per kilo. So, for example, a 70 kilo person, you're looking at 350 to 400 mils per breath. When I started in ITU, we used to commonly deliver 10 to 12 mils per kilo. But this is a tidal volume. So each breath, how many mils are we delivering in each breath? And then secondary from that, you're going to get something called the minute volume. And the minute volume is basically the tidal volume times the respiratory rate. So just to make my maths easy, let's say we're going to give them 500 mils per breath, and we're going to give them 10 breaths per minute, then their minute volume is going to be 5 litres. Every minute, they're going to get 5 litres of oxygen. Okay. The other important thing that we're going to set is going to be their FiO2. So FiO2, what does that mean? Well, FiO2 is fractional of inspired oxygen. Okay, so fractional inspired oxygen. So basically, what percentage of oxygen are we giving them? So if you hear FiO2, just think oxygen percentage. So our patients, obviously, 21% is room air. Our machines can deliver 21%, but they can also go all the way up to 100%. Okay, there's lots of reasons you won't want to give patients more than sort of 60 to 70% for any prolonged period of time, but sometimes that's what our patients actually require. So we can go up to 100% on these ventilators. So all these numbers down the side are telling you these things. The other thing one of the other values that will often come up is something called, let's see if I can grab a different color, is something called the peak pressure. And we do get very excited about peak pressures. This is how hard the machine is having to push to get that air into the patient's lungs. And we really don't want that going above 30 centimetres of water. We measure things in centimetres of water. We don't want it going above that because then you're starting to damage the patient's lungs. So we will talk about peak pressure. You'll hear plateau pressure as well, but let's not worry too much about that. Just think about peak pressures. So these are the key things on the ventilator that you can see on here, which is what the machine's telling us, and it's not very clear on here. You can see on there, that's what we're setting in the machine. So we're adjusting these numbers here, and that's what the machine is telling us is coming out. I'm not going to go into the waveforms. Again, if you're not experienced with ventilation, probably waveforms is a bit too much anyway. So that's the basics. That's what the ventilator is doing. And if you just think of as a ventilator as a leaf blower, but with some restrictions on what it can and can't do, which is set by us. Okay. So I'm going to use Sam's terminologies here just to explain some of the other words that you may hear used. So let's just get rid of this for now. Okay, so I'm just going to pick out some of the words that she's chosen here. So we've talked about tidal volume, we've talked about minute volume, we've talked about FiO2. I'm going to talk about spontaneous breaths. So you will get what's called mandatory breaths. Can't spell. Mandatory breaths and spontaneous breaths. Okay, and you also get assisted breaths. Now, at their very basic, the mandatory breath is a breath that the machine will deliver. So if we say to the machine, okay, you will deliver 12 breaths every minute, a mandatory breath is one of those 12 breaths that the machine will deliver regardless of what the patient's doing. So the machine will always deliver, it's going to deliver one breath every 6 seconds, regardless of what the patient's doing. Assisted breaths are if the patient initiates a breath, so they start to breathe for themselves, the ventilator will detect that breath and will give them a bit of assistance in taking that breath. So it will apply things like pressure support, which don't worry about, but that's just an assisted breath. A spontaneous breath, at its simplest, is basically the patient takes a breath. The machine doesn't provide any support other than delivering the gas that the patient demands. It doesn't provide extra pressure, and the patient is responsible for pretty much all of the breath. Now, what happens is that when the patient is really sedated, so let's say they're really sick, they're on 100% oxygen, we've got them very heavily sedated, the ventilator is delivering pretty much all of the breaths. So it's getting all of the mandatory breaths. So if you set the ventilator to a rate of 12, chances are the patient, that all the breaths will be, it will just be 12 breaths per minute. That's all that will be delivered. As we start to wean them off the ventilator and we want the patients to do a little bit more, so the sedation goes down a little bit, then the patient will start then getting some assisted breaths. So the patient will start to take some breaths and the machine will detect that and say, okay, take the breath and I'll give you a little bit of assistance as well. Stick your head out the car window, breathe in, it's going to be a little bit easier. When they're more and more awake, eventually we're going to get the patients, and these are the patients who are sitting there, they're awake, they're not sedated anymore, they've still got the tube and they're not quite ready to take off the ventilator. We start delivering spontaneous breaths. So the patient takes a breath, the machine says, okay, I've detected you've taken a breath, but it's all down to you pretty much. I'll deliver whatever you demand, but I'm not going to provide any extra support. So they have to work harder for that breath, basically. RAS. Okay, so the Richmond Agitation and Sedation Scale. So, again, I'll rub this out. We want to be sure that we are not over-sedating our patients. It's important that they are sedated to a degree, but if we over-sedate them, when we do decide to wake them up, it's going to make it harder and harder, and it's going to take them longer and longer to wake up. So we use something called the Richmond Agitation and Sedation Scale, and it goes from +4 to -4. Ideally, the ventilated patient should be sort of -2, -1, -2, -3. So ideally, you should be able to shout the patient's name. The patient should be able to open their eyes in response to you shouting their name, and that's the ideal sedation level. If they're moving a little bit, as long as they're not pulling things out, we should be tolerating that as well. So you'll often hear people say, what's the RAS score of the patient? And that's about how well sedated they are. We talked about the closed circuit suction. We've talked about the HME. We do occasionally give them nebulizers, so you can give them nebulizers via the circuits as well. So, I mean, that's pretty much all I want to say about the ventilator. Obviously, it's the life-saving piece of equipment that everyone talks about. It's the piece of equipment that's often referred to when people say they're on life support. It's going to be the ventilator. They are all more complicated than they used to be, but also they are not to be frightened of in experienced hands. But obviously, if you're not experienced, then this hopefully will give you some of the terminology that may or may not be used. And again, I just want to make sure that you understand that this was created by SamIam_UK from Twitter. This is her work. You can go to her website, which is What Would Florence Do? I think that's what it's called. Yeah, What Would Florence Do? And you can download these. She's got a series, all of which I'm going to cover, hopefully, again, like I say, with her consent. So that's the ventilation basics. As I say, the ITU nurses will be looking after it, but I think if you're going to end up in ITU helping out, it's nice to have for you to have a basic understanding of what's actually going on. Hello again. Light. Hello again. For those of you that are new to the channel, my name is Jonathan Downey.